Welcome back to another episode of Oncology for the Inquisitive Mind, coming to you live. Well, not live, because we're recording this, but semi-live from beautiful, sunny Barcelona. And Josh, before we dive into day 2 of the European Society of Medical Oncology, I just want to share something with you. My wife was on social media and saw a post from our native Melbourne of one of her friends, and they were attending an outdoor netball game in the hail. So I think what I'm trying to say is we're very lucky to be here.
Yes, and social media is not very good.
It's not very it's not very inspiring, is it? So, Josh, we have a ton of stuff to get through for day 2 of ESMO. Why don't you start? Because your first couple of studies actually aren't related to any type of direct cancer treatment at all. And if anything, that makes them more interesting.
Yeah, so I'm going to be talking to you here in Barcelona about some supportive medication. So one of the main issues we always have with people with metastatic cancer is weight loss. It's a huge thing. There's a lot of evidence to support that weight loss leads to cachexia, which leads to poor tolerance to treatment and poor outcomes. So the trial I'll be discussing is called the Cachexia GDF15 trial. This is an efficacy and safety of a drug called ponsegromab, which is a growth differentiating factor 15 inhibitor with cancer cachexia. So the study was randomized, a double-blind trial. Primary endpoint was at 12 weeks, essentially looking for weight gain, and there was an optional open label extension up to 1 year. The background I've already gone through, but what we're trying to do here is essentially maintain people's health and weight so they can tolerate treatment better. Baseline characteristics are pretty well balanced. The main cancer subtypes that were included in this trial included non-small cell lung cancer, colorectal, and pancreatic cancer. Most patients had stage 3 or stage 4 disease, and greater than 90% of patients on each arm was on active therapy. So 187 patients were enrolled, 73% completed the 12-week visit, and 80% of those have gone on to the option extension study for up to 1 year. And this was also a dose escalation study. So there were 3 doses of the drug, and what they found is that the 400 milligram dose, there was a statistically significant placebo-adjusted modeled median increase in weight for both the 100 milligrams, the 200 milligrams, and the 400 milligrams, ranging from 1.33 kilograms to 3 kilograms, which is exciting, and this was maintained. So the results showed there was also benefits in patient-reported outcomes, muscle mass, physical activity, lumbar skeletal muscle index, and non-sedentary physical activity increased to about 50 minutes per day. Adverse events are quite similar between the placebo and the intervention group. And as a summary, Michael, it was an exciting trial. And it shows that there is an unmet need for these patients to maintain their weight. And this, although an earlier phase study, would be really exciting to kind of further expand and see how that goes, but something really great in the supportive cancer field, which we don't get that often.
No, and I think if you're one of the breed of oncologists who likes to focus on systemic therapy, which of course is fine, there's something in this study for you as well, because we all know that if you, as Josh said at the start, if you are fitter, if your weight is more stable, you are more likely to tolerate treatment for longer. It's, why studies only enroll people with an ECOG performance status of 0 or 1. So there are consequences not just for quality of life, but for increasing the delivery of treatment. Josh, you've got another supportive care study that you'd like to talk about, featuring our old friend, 2 of our old friends, olanzapine and TDXD.
Thank you, Erica. I mean, this trial is called Erica, just a slip of the tongue. So this is an olanzapine-based triplet antiemetic therapy for prevention of delayed and persistent nausea from TDXD. So trastuzumab, deruxtecan, the Hail Mary of HER2-positive breast cancer and almost every other cancer, either now or in the future. You heard it here first. has some significant tox, and one of those big toxicities is nausea. Nausea to the extent that people don't eat, they lose weight, and it can lead to treatment interruption and treatment cessation and dose reduction. And we do have a number of treatment options for nausea, but they're looking to see whether olanzapine, a multiple neurotransmitter receptor blocker, could help in combination with a 5-HT3RA and dexamethasone. The primary endpoint was no emetic events and no rescue drugs required during the delayed phase, and they were given either olanzapine or placebo during the course of their treatment. There were 82 patients in the intervention arm and 83 patients in the control arm. Demographics were well balanced, with the primary endpoint showing that delay in nausea occurred in 70% of the intervention arm and only 56% in the controlled arm, which had persistent nausea. There was no nausea seen throughout the 21 days of the olanzapine usage, and the median time to onset of nausea was 6.5 days for olanzapine versus 3 days for placebo, and the median total days of nausea was 4 days for the olanzapine and 8 days for those who did not have olanzapine. Toxicities was slightly high in the olanzapine group, and in summary, it actually shows that it delayed the nausea from the 24 to 120 hour mark and was significantly high in the olanzapine cohort. And this is a really exciting update. We do use this a lot, but I think it's really important to know that if you can get your patients to eat, they're going to very much engage with therapy a lot more.
Yeah, I don't think I need to tell anyone who's listening that it's among our patients' greatest fears when we talk about systemic therapy that they won't be able to eat. I think not being able to eat and losing your hair are the two most common patient concerns, Josh, when we're discussing any sort of systemic therapy.
100%. And I think each patient is also individual. So that's a broad sweeping statement. And there are those that do have other preferences, but that is the most common. I agree with you, Michael. But speaking of not being able to eat, head and neck cancers can cause just that. And you've got two hopefully inspiring trials to discuss with us today in one of the loves of your life, head and neck cancers. Michael did his fellowship in head and neck cancers, and I'd love to hear what you have to say.
Absolutely. I was very excited about these two studies because they aim to answer the most commonly asked questions in early head and neck cancer, and that is the provision of cisplatin, whether we give it in a 3-weekly fashion at 100 milligrams per meter squared or in a weekly fashion with 40 milligrams per meter squared. It's been a seemingly eternal debate, and the current consensus up until today was that whenever you have patients who can tolerate or are likely to tolerate the 3-weekly regimen, you try and get them through at least 2 out of the 3 doses of the 3-weekly regimen. However, the JCOG-1008 study was a non-inferiority study that explicitly tried to compare weekly versus 3-weekly cisplatin in combination with radiotherapy in the locally advanced head and neck space. They enrolled 261 patients, and what was presented was the final overall survival data. What they found, interestingly, was that 3-weekly cisplatin had a higher cumulative dose on average for patients, but weekly cisplatin had a higher dose intensity. I'm honestly not quite sure what the difference is, so if you are pharmacologically inclined, please reach out to us and give us a bit of education. We'd love to hear from you on this particular topic. But now to what we like to call the juicy part, and this got, I think, certainly me, but I think a lot of people quite excited in the audience. After a median follow-up of 5.6 years, the hazard ratio for overall survival, comparing 3-weekly to weekly, well, weekly to 3-weekly, I guess, was 0.69 in favor of weekly cisplatin, which was not what I was expecting. I think we've always said we know that 3-weekly cisplatin has a higher toxicity profile, but that's the trade-off for a higher efficacy. This is a non-inferiority study, so I don't think you can specifically say that weekly is superior to 3-weekly, but numerically, the survival is significantly higher. The 5-year overall survival rates were 71.2% for the weekly cisplatin and 58.7% for the 3-weekly regimen, for a hazard ratio of 0.76, and the p-value was statistically significant. The 5-year recurrence and local recurrence-free survival was also 11% higher in the weekly arm. And there was lower toxicity rates as well. This is actually quite a nice segue to the second study, which is radio. And this was looking again at 3-weekly versus weekly cisplatin, but specifically at that most bothersome toxicities, which is ototoxicity. I think we've read previously that the main driver for cisplatin ineligibility in these patients and in the bladder cohort as well is actually renal impairment, but clinically, ototoxicity is one of those things that you're really mindful of with cisplatin. The long and the short of the radio study that enrolled 99 patients and looked specifically at rates of hearing loss in patients with weekly or 3-weekly cisplatin, the weekly cisplatin had a overall risk ratio of 0.39, so a more than 60% lower risk of ototoxicity of a grade 3 severity favouring the weekly regimen. There was also a higher quality of life scores in patients with the weekly regimen compared to the 3-weekly regimen, but this was not statistically significant. So a couple of what I might call in certain places that I've worked, practice-changing trials, Josh, because if I have a patient with head and neck cancer now, rather than trying to push them through the 3-weekly regimen, I might actually preferentially try weekly cisplatin because it's definitely not worse, it might even be better, and it has lower toxicity.
Yeah, that's really quite interesting. Lower toxicity and better overall. I think you solved the trial, Michael.
That's what we like, is lower toxicity and more efficacy there, Josh. We might move on to breast cancer, if you're up for it, because there were a ton of studies on this day focusing on breast cancer that are very interesting.
So many. Is it my turn, or do you want to keep going?
Well, I've been speaking for about 4 minutes, so why don't you try?
Oh, you're so generous. Thank you. I wanted to talk about a 10-year update for the short HER study. This is quite interesting. So it's in the cohort of early stage HER2 positive breast cancer, and it was a phase 3 trial, and it was looking at 9 weeks versus 1 year of adjuvant trastuzumab. It's a dose de-escalation study, which is something we really love. I love the fact that trastuzumab is one of our best drugs and probably has fewer of the side effects when we actually talk about how we run our treatments. But either way, it's still really interesting. Would you agree?
I would agree.
Very, very good. I'm just looking for my notes as I sort of fill it in. And what this trial was looking at is TILs, Michael. And TILs are these infiltrating lymphocytes, tumor infiltrating lymphocytes that you hear in most studies. And they say whether they're high, they say whether they're low, and you don't really get an idea of how am I actually going to apply this in real world evidence. Like, high, is it bad? Low, is it bad? And can this help influence de-escalation? And so the background is that they kind of had this cutoff of 20% for the TIL. So if you had greater than 20% versus less than 20%, they wanted to see whether or not you could de-escalate and looking at outcomes. And what they found that with low TILs, there was more benefit in those that were treated in the long arm, being the year of adjuvant trastuzumab, versus the short arm, which is the 9 weeks of trastuzumab. And in the high TILs cohort, there was benefit irrespective of treatment arm. And it was numerically better in the short arm. And so you found improvement in both distant disease-free survival and overall survival. And what I really loved, and you're like, this is already done, Josh, you've finished this trial. What I loved about this trial is that you could probably help, and I don't know if this is going to be mainstream or adopted in Australia yet, but it could help influence de-escalation. And what are the benefits of de-escalation? Essentially, less cost to the healthcare system, less cost both financially and time-wise to the patient, and less risk of having sort of really some bad adverse events, which you can still have even with things such as trastuzumab. So I thought it was worth its limelight. It's in the spotlight today. It was around last year as well, I think, at ASCO, but here we are again sort of reporting on it, and it's a really interesting trial.
I would agree, and everyone who listens to us on a regular basis knows that we are very much in favour of any form of treatment de-escalation. My study, Josh, because I think we're just going to bounce back and forth on the breast cancer aspect, is a Dutch registry study that looks at PCR rates after neoadjuvant treatment of triple-negative breast cancer that is stage 1. And at first glance, I thought, okay, well, what's this actually going to add to the literature? Because we know that neoadjuvant treatment increases PCR rates. PCR rates are associated with better outcomes, etc., etc. But Josh very astutely pointed out to me that stage 1 cancers are excluded from most of the pivotal neoadjuvant trials, certainly from Keynote 522. And so the effectiveness of neoadjuvant treatment in these patients remains an unknown. So despite that, likely because of all of the existing evidence on PCR rates, the clinical use of neoadjuvant chemotherapy for stage 1 triple-negative breast cancer is actually increasing. So this was a Dutch registry study that enrolled 1,144 patients. And patients were treated, it's important to note, with chemotherapy alone in the neoadjuvant setting. They did not receive immunotherapy because immunotherapy is not approved for stage 1 triple-negative breast cancer. The PCR rate in this study was 57.3%, which is interesting because it is actually numerically lower than that in the Keynote 522 study. And this is where we say you shouldn't have cross-trial comparisons, etc., etc., etc.
We really shouldn't do cross-trial comparisons, etc., etc., etc.
Thank you, Josh. It's almost like I summoned that. I'm going to start calling you Beetlejuice. But it is interesting that a quote-unquote lower risk or lower stage breast cancer has lower rates of PCR, and this probably speaks to the heterogeneity and the fact that, to quote previous guest of ours, Adam Brufsky, that tumour size and nodal involvement is not the be-all and end-all of breast cancer prognosis. The overall survival rate had a hazard ratio of 0.29 in patients who had a PCR compared to patients who did not, and PCR was the only highly significant variable that allowed for a prediction of overall survival. There was no increase of overall survival for patients who did not receive adjuvant capecitabine, which was also interesting. So to conclude this study, PCR is associated with overall survival outcomes, better overall survival outcomes, even when you're talking about small stage 1 triple-negative breast cancers. There was no benefit of adjuvant capecitabine, and again, these patients did not did not receive immunotherapy. So I think it reinforces that there is a place in triple-negative breast cancer, in stage 1 triple-negative breast cancer, for neoadjuvant treatment, and we still need to aim for those PCRs because the outcomes, even for small triple-negative breast cancers, are still there's still room for improvement, shall we say.
Well, there's room for improvement with everything we do.
That is true. That is true. We should always strive to be better in our jobs.
That's it. I might jump to lung because I feel we should do something that's not just breast cancer on this podcast, if that's okay.
Absolutely. I don't think we can reasonably expect ourselves to cover everything, even though there was so much today.
That's it. And, they're galaxies apart, lung and breast cancer. But here we are talking about the Galaxy's Lung 201 trial. It was an open label randomized platform study. We see platform studies occasionally, and I think what it really is you're just randomized to multiple different arms within the same trial. And that's sort of how they did it. And so the sub-study that we're looking at today has 4 different arms. One is just dostarlimab, which is a immunotherapy agent, plus belrestotug, which is a mouthful. And belrestotug is an FC-active human immunoglobulin G1 monoclonal antibody targeting T-cell immunoglobulins and immunoreceptors, in case you didn't know, which I did not before looking this up. And this is a group of patients who are previously untreated, unresectable, locally advanced or metastatic disease with a high PD-1 with a TPS score of greater than 50%, and they had to be EGFR ALK wild types and no sort of targetable mutations, and asymptomatic and treated brain metastases were eligible. They were randomized to multiple trials, either single agent or a combination of the 2 drugs that I've mentioned, of different dosings of the belrestotug. The primary endpoint here was objective response rates, and the key secondary endpoints are all those that I personally love: progression-free survival, overall survival, duration of response, safety, PK, etc., 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 etc. Now, what you might see that we're omitting here is there is no chemotherapy. Pretty darn cool. And so it was a dose optimization study, and there were several arms. And this has previously, I think, been done in Pembro, but we're using dostarlimab in this particular case. Demographics: male, Asian predominance, good ECOG status. It was well balanced. What they found is that the combination showed clinically meaningful improvements versus single agent dostarlimab, with an objective response rate of 37.5% for dostarlimab, and a combination range from 63 to 76%, with a confirmed objective response rate of about 60%. ctDNA, love a bit of ctDNA. There was trend towards numerically greater ctDNA decrease in the higher belrestotug dosing. Adverse events: there were some grade 3 to grade 5 events, myocarditis. There was also mostly cutaneous, such as dermatitis, pruritus, hypothyroidism, and myocarditis. So in conclusion, this is the largest prospective RCT, that was phase 2, of a combination of an anti-TIGIT and a PD-L1. Belrestotug, it's a differentiated anti-TIGIT monoclonal antibody, which I didn't mention at the start, but it's probably important for me to say that. And I think there's going to be ongoing follow-up and ongoing recruitment, and it's going to be really interesting because this is one of the first trials. And yes, there is another Keynote, not 189. I can't remember the other trial, but essentially it's immunotherapy alone for high PD-1, which you can use for frail patients with metastatic non-small cell lung cancer. But it's another option for patients if it ends up showing good PFS and OS, where we can omit chemotherapy altogether.
And that's something that we absolutely like. Josh, in the interest of time, I might speak about one more, and then you can speak about one more, and then we'll let our lovely listeners get on with their day.
You're such a benevolent leader. Thank you.
I am. Someone's got to rein this show in. So the last study that I want to talk about is an early phase study, a small early phase study out of China. And it is looking at ivonescimab plus ligufalimab, and I apologize profusely if I've completely butchered those names, plus folfoxiri in the first-line treatment of metastatic colorectal cancer. Now, there hasn't really been too much movement in the MSS, that's the microsatellite stable pMMR colorectal cancer, for quite a while. It's been chemotherapy plus a sprinkling of bevacizumab or cetuximab, and that's been pretty much it for a while. Ivonescimab is a tetrametric PD-1 plus VEGF antibody, so you're getting both the immunotherapy and the anti-angiogenic effect. And ligufalimab is a monoclonal antibody that targets CD47. And the idea behind this is that it is an adjunct, that it increases the anti-tumor effect. So this was a study of untreated patients with metastatic colorectal cancer, and importantly, patients that were MSI high were excluded, which I think is very reasonable because you know that you're going to get some benefit from PD-L1 blockade. And so there's not really much point in including them in this trial. We're trying to overcome that resistance to immunotherapy. Small trial of only 40 patients. However, the results were very promising. There were 2 arms, and one included ivonescimab plus chemotherapy by itself, and the other was the quad therapy, so ivo plus ligu plus folfoxirate. That's probably actually about 5 or 6 agents, one would expect. So the overall response rate with ivonescimab by itself was 81.8% and 88.2% in the patients that just got everything. The disease control rate was 100%. So that's patients who had either a measurable response or stable disease. So 100% of 40 patients had some measure of disease control. The 9-month PFS was 81.4 compared to 86.2%, so really good outcomes, although you would expect patients receiving just folfoxiri by itself to last 9 months progression-free survival. The median PFS has not been reached in both groups, and the toxicity profile appeared fairly tolerable because the most common grade 3 side effect was low neutrophil count, which you can probably assign the blame predominantly to the chemotherapy. There is a phase 3 study that is examining these agents, and I'm very, very excited for it because we really do need a quantitative leap forward for the MSS colorectal cancer patients. They've sort of been left behind in the immunotherapy revolution. And so if this can prove to be something that is worth examining further, then that would be very exciting.
I agree that they have been left behind in really most revolutions. Colorectal cancer in the metastatic setting, early cancer you can reduce with chemotherapy, but metastatic, there's 3 lines and then it's a trial. There's nothing else.
Exactly. And then you're sort of looking down the barrel of Lonsurf and fruquintinib, and it gets very grim very quickly. Josh, you have one last study that you're just itching to talk about. Why don't you tell us about...
You don't know what I'm talking about, do you?
No, I don't, because you're just scrolling up and down. This is what Josh does. He keeps us on our toes.
See, I was choosing between another colorectal study or a breast cancer study, and I think I'll talk about this breast cancer study briefly. You might have heard of it before. It's called the Natalie trial. It's looking at ribociclib in the high risk cohort of breast cancer, early stage, to try and reduce that risk of recurrence. It's 3 years worth of treatment. I think we're still waiting on OS data, but it's getting close. And so what we know as a background, there's also the Monarch E trial, which is abemaciclib. That there is a role of the CDK4/6 inhibitors to reduce the risk of patients who have very high risk features of their early breast cancer. I'm talking about grade 3, multiple lymph nodes, size. There's usually a criteria, and they're slightly different depending on which trial you look at. And we know what's been shown with this trial is that the absolute invasive disease-free survival is about 3.1% with a hazard ratio of 0.79. That's already been proven. Demographics, what they've found is that there's more young patients who presented with advanced disease. There's usually a higher rate of stage 3 in the demographics of this cohort. There's higher nodal positivity, higher rates of Ki-67. And they wanted to compare young versus old patients. When I say young versus old, that's not actually they're old, it's under the age of 40, over the age of 40. And they found that the invasive disease-free survival benefit was actually higher in the under 40s with a hazard ratio of 0.54 versus 0.78 for those over 40. With an adjusted hazard ratio of 0.59, the absolute benefit found at the 3-year mark was 5.1% in younger patients and 2.8% in older patients. But you can't formally compare that because it wasn't statistically built to compare younger and older. But an interesting point, and also quite a significant absolute benefit if you had to ask me yourself. And efficacy data, the distance disease-free survival was slightly better in the younger versus older patients. I wanted to bring this up because I think it's important that we can kind of understand that patients who are younger, who have cancer, probably have a more aggressive biology, and then things like treatment escalation and toxicity and those things do need to actually have a strong conversation. And I think that was really all I wanted to say with regards to the Natalie trial, Michael. Did you have any questions?
None at all. It's one of those studies that feels like it's been around for ages. And it's always nice to just have these details just dripped out and slowly give us a bit more clarity on how to treat our patients. That concludes our episode on day 2. If you are following ESMO as closely as we are, you might notice that there are a few trials that were missing, and those were the big practice-changing trials at the end of the day. We are going to give them the attention that they so richly deserve, but that will be in its own episode. We like to save the best for last for these major conference coverage series, and we're going to do exactly that. So we hope you keep listening, because the best of the best, including Podium and Piece 3, will be coming to you in our final episode in this series. So we hope that you'll stick around for that.
Michael, you are a very persuasive person. Peduncle. Anyway, we're going to go get some lunch because it's beautiful here in Barcelona. Don't forget to like and subscribe. Leave us a comment. Send us an email. Let us know what you're thinking, and we will see you tomorrow.
Thank you for listening to Oncology for the Inquisitive Mind. This episode was produced by ADC Productions, with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. However, we do not allow creative or editorial control or even early previews of any content. They are hearing this episode alongside you for the very first time. If you like this episode, there's plenty more where that came from. Check out our website, inquisitiveonc.com, for all of our previous episodes, and make sure to subscribe to be the first to hear new content. If you'd like a particular topic covered on the show, or just want to chat, drop us a line on Twitter @inquisitiveonc or by email on inquisitiveonc@gmail.com. Thanks for listening, and we'll see you next time.